excited to do this with you.
Me too. I've never actually done an Insta Live before, so.
Well, I just started doing them. This will be my third or fourth one.
I love it.
Yeah, it's a good way to get questions answered, and then the video gets stored on my Instagram under the little icon for Insta Live, and then that way people can go back and look at it if they get to join.
Perfect.
So, yeah. So we'll wait about 5 more minutes.
Okay.
You said you were getting your kids to bed?
Yeah. Well, I get one to bed because I'm breastfeeding her, and the other one, my husband gets to bed, but of course I still have to read a book and put her to bed myself.
Yeah. So people are asking, yes, we're going to save it. After the video ends, it gets saved on Babies After 35 under the Instagram Live tab. I don't want to log out, but you'll be able to see it where you can see my feed, and then there's a little TV for Instagram Live. You click on that, and then all the Instagram Live videos are saved there. So you'll be able to go back and watch it if you can't stay on. Okay, so yeah, my twins are 3, and this is our last day of spring break. I was actually home all last week. We were supposed to be in San Diego. Of course, that didn't happen.
Yeah.
So I'm hoping the hospital's got everything worked out before I get there tomorrow.
Yeah.
All the kinks worked out. Have you been working this past week?
Yeah, I have. It's been daycare's still open for now.
Oh. And you're in Minnesota, right?
Yeah. It's Rochester is a very small town, relatively, I guess. So we haven't really seen many cases yet, but we tried to switch all of our consults to telemed consults. Yeah, telemed. It's been interesting because we haven't really done that before. So it works for the most part.
Yeah, we're consolidating. We have 6 MFMs. We cover labor and delivery 24/7, so we're still doing that. Wow. Yeah, so, and our fellows take Fridays and Saturdays, which helps. So, but we used to we did go out to some of the clinics where they funneled down the high-risk patients, but now we're doing that by telemed because he's trying to preserve us, I guess.
Yeah.
Because of
labor and delivery and MFM, huh? And ultrasound.
Yeah, and I have a C-HIST first thing in the morning, my first day back in 10 days, so. Hi, the Bauer Farmhouse. I know you. 3 more minutes, guys, and we'll get started.
Perfect.
And just whoever's on, you guys know you can comment and add questions. I may not get to them right away, but I'll see them as they scroll. And sometimes I do, I will pause and go back and answer questions throughout the time. We're going to try to keep this down to 30 minutes, depending on how many questions we have. There's still a lot of questions, I'm sure Dr. Alrahmani will be hopefully willing to do a second session.
Absolutely.
So we'll just, sometimes that happens. And, but I found that, there are questions already coming through. We got 2 more minutes, guys. Let's go. Where'd you go? Let's go there. Okay. This is from Shuby 12. If you have a perinatal sonogram team, are they working? I ask because since the distance from patient to patient is not much, how are you guys going ahead about that? So basically what we're doing in our center is, unless there's a complication, new entry to care, or a newly pregnant woman is going to get her first ultrasound at 18 weeks unless there's an issue, or she has a reason to have it earlier. We're not doing, you could tell me, you can speak on your center too. We're not doing the NT screens and that right now. We're doing the quad screen. But as far as ultrasound for the newly entering care women, they're going to get it at 18 to 20 weeks unless there's a reason to do it before then. Or, if they need to do serial cervical links or something like that for preterm labor, we'll bring them in earlier. What are you guys doing?
We haven't really canceled much. So we have been doing, so we started doing first trimester anatomy ultrasounds last year.
Okay.
I think that's really the only thing that's sort of, elective that we're going to be able to, get rid of for a little bit at least.
Yeah.
But it's been just as busy as always.
Yeah, so,
it hasn't been different.
Yeah, so Shuby, I think it depends on your center. So our centers get kind of cracking down now. I know some centers are even more strict as far as when they're bringing patients in. It all depends on what the disease burden is in your area per se.
Yeah.
So if you have questions, Shubi 12, I think you need to talk to your doctor about it, because they're trying just to limit the number of ultrasounds women are getting, unless they're indicated, of course, and then preserving the ultrasound techs and the doctors and everything, in case it does get hit. And then the next question is, how many pregnant women do you know that have contracted the virus? In my area, we have not had any in our hospital yet.
We haven't had any yet either.
Yeah, but I also think it's, I know there are some in the Northeast. I know there are some in Atlanta. So, but fortunately, I have not, I could be wrong, but I have not heard about any pregnant women being severely ill at this point. So, but again, I think if you have questions, it all depends on where you are in the country. You should ask your doc to say, hey, have we had any in our area? Because the OBGYNs in each individual area are pretty much getting updated on those patients. Would you agree with that?
Yeah, absolutely.
Yeah. Okay.
Yeah.
So those are two. Okay, here. No, so this is from Fit. I'm just gonna say Fit and Pretty. Is this just a Q&A about COVID-19 virus impacts? No. This is actually the reason for this was for the discussion is should pregnancy after 35 be considered high risk? We could potentially do another one on the COVID. I'm just going to speak at the top about COVID right now. It's very scary for pregnant women. The main issue that we know right now with the COVID virus is if a woman gets sick early in pregnancy and has a high fever. Anytime a woman has a high fever with any of these viruses, even the flu, there is a risk to the baby earlier on. Later on in pregnancy, the risk is if she becomes severely ill with the fever, it could cause preterm labor, or if she gets respiratory compromised, and that's also obviously an issue for mom and baby. So with the flu, and like when we had H1N1 several years back, or the swine flu, where it really hit pregnant women hard, we're not seeing that COVID is doing that with pregnant women as hard as the H1N1 did. I think it was back in 2009 or so. That's a good thing. And I haven't heard anything different. Have you heard about similar to what I just said as far as COVID and pregnancy?
No, I think just exactly what you said. All the everything that's in the literature shows that everyone has done fine so far, but there's only been like less than 20 cases, I think, reported in the literature so far from what I last checked. So.
And I know there is a center that is doing a database registry for any of us that are treating pregnant women with COVID. So hopefully we'll all start turning in our cases to that so that we can get some more information. So with that being said, we have several people. Okay, hold on. Oh, Shubi said she's in the center. I get it. I know you guys are worried about that. But what we're going to do is we're going to start with the topic at hand, which is should pregnancy after 35 be considered high risk? I want to introduce Dr. Alrahmani. She is at the Mayo Clinic. She's also maternal fetal medicine, and as am I. I'm at a center down here in Galveston, Texas. So we're just going to have some talking points. If you guys have any questions along the way, you can enter the questions here. So the first thing I wanted to talk about is I get a lot of upset women when they hear advanced maternal age, geriatric pregnancy, elderly, prima gravida. And I just want to say that actually those are actual codes that we use in women over age 35, and they're what we call ICD-9 codes, and they're used in pregnant and medical practice. And that's because even back when I first started training, I was in residency 2000 to 2004. We didn't have as many women as we have now that are pregnant after 35. It's becoming much more commonplace. The average age of the first-time mom is increasing, and a lot more women are having babies after 35 and 40. So although the terminology is not flattering, it is what it is. And hopefully, would you agree that maybe one day it might change? Hopefully.
Absolutely.
Yeah.
You can tell that a woman didn't come up with this name, I think.
No, I'm pretty sure that is the truth.
Yeah.
So, I think, maybe one day when I have a little extra time, maybe I can try to lobby to get that changed to something more appropriate.
Yes.
So what I want to tell women about that is, yes, it's not flattering. It is what it is. But don't make too big of a deal out of it. One day it's going to change. I think all of us don't look at women over 35 and 40 and think that they're elderly or geriatric. We get the terminology is not appropriate, but there's not a whole lot we can do about it at this point. But I assure you that all of us are not in the back of our heads thinking there's something abnormal with a 35 or 40-year-old being pregnant. I see a lot of them now. What about you?
Yeah, definitely.
Yeah.
I mean, so the patient population that I cater for, generally, I would say at least 50% of them work at Mayo. So they're all, women with careers and decided to delay childbearing for, different reasons. And I think that's, the average age of childbearing is increasing. So we're going to see it more and more.
Well, and also with the advances in assisted reproductive technology, such as IVF, we are having more and more women, especially over age 40, who are having pregnancies. So
exactly,
we're all going to have to get used to it. It's there. It's not going away. And we do try to be very, despite the terminology, we do, hopefully the docs are being very respectful of you and not making it too uncomfortable with that terminology. Okay. So the next topic I want to bring up is being over 35. Does that mean that you automatically have to see a high-risk specialist? I can say at my center, everybody starts with a routine obstetrical care provider. Yeah. It all depends on that obstetrical care provider. And I say that as a generic term because it's not OBGYNs that do obstetrical care. But for the purposes of this, because it's a long term, I'm going to say OBGYN. But I don't mean any disrespect to any family practice docs or midwives who are doing obstetrical care either. So let's just say your OBGYN may send you to a high-risk specialist because there's something in your pregnancy that makes you high risk, whether with you, it's a chronic medical condition, or with the baby, or they just want you to be seen for a detailed anatomy scan or for genetic counseling because you're over age 35. That does not mean that the MFM is going to take over your care. They may just see you that one time and be done. Yeah. Or there may be a reason to see them in consultation periodically, or your OBGYN may determine for whatever reason that they're not comfortable managing your pregnancy and they want an MFM to manage your entire pregnancy. Is that generally how you guys do it at Mayo?
Yeah, so we're mostly a consultative practice. We do keep some of our own patients if they're very high risk, like if, fetal anomalies, trisomy 21, Down syndrome, things like that, or maternal disease. But just advanced maternal age by itself, pregnancy over age 35 does not make you specifically high risk. We may see you for a consult or may not see you for a consult at all.
What I generally tell women is if they're otherwise healthy, the main risk, just being over age 35, of course, is the increased risk of having the genetic defects. So I do recommend that all women over age 35, and I'm just going to put this out there, that they get some kind of antenatal screening. A lot of women will say, no, it doesn't matter. But what I see a lot of times is they decline the antenatal screening, which is a quad screen, an NIPT, nuchal translucency or whatever. Then they go to their anatomy scan, and there might be something minor that's there, where it's easier for us to counsel you about the significance of that if we had that screening. And if we don't have the screening, then it's a little bit more difficult for us to put things in language that the patient might be able to understand. So it's your choice, but I feel it's a lot easier for us if we do see something on ultrasound to counsel you more thoroughly if we have that antenatal screening, especially if the antenatal screening is negative. Would you agree?
Absolutely. So I always say there's nothing magical that happens at 35. Mm-hmm. The risk gradually goes up. I think once upon a time, someone decided that the risk for Down syndrome is considered high at like 1 in 350 or something. So, and they decided that 35 is it. And I think that we associate everything with 35. But again, your risk is not that much lower at 34 or 32 even. Mm-hmm. I mean, everyone has a risk. It's much lower, obviously, in your early 20s, but it does.
But in general, more women under 35 are having babies with Down syndrome because they're having more babies. Right. But there's a higher percentage in women over 35 and especially over age 40. Exactly. And originally it was because the risk of having a baby with Down syndrome was directly equal to the risk of having a complication from an amniocentesis. But that's why 35 became the magic number. Right. But now the risk is actually lower with amniocentesis because, we've had more of them done and we've realize that the risk is not actually as high as it once was considered.
Right.
So, in some, 37 to 40 might be becoming the age where the risk is really there. I don't think it's going to change anytime soon where we're going to say, okay, now 37 is advanced maternal age.
Right.
It's 35, it's fine.
Yep.
It is, like I said, it is what it is. But as long as you're otherwise healthy, I do recommend getting that antenatal screening because I can't tell you how many women declined it. And then we might see something what we call minor markers, which are not birth defects on an ultrasound, but they do alter a woman's risk of having a baby with chromosomal defect. And if we had the screening, we'd be done if it was negative. Whereas if we don't have any kind of screening and we see something, then we have to start counseling and talking about all this stuff. Whereas we wouldn't have had to do that had we had the screening. So I'm a huge advocate for the antenatal screening.
Yeah. When I first moved to Minnesota, it was very different where it was more of an opt-in test, which I trained in Detroit, my residency. So everyone kind of got it if they had early enough prenatal care and they wanted it, but it's very different. People in the Midwest, I think generally, at least the patients I see, don't want it. And then they almost always do change their minds once we find something. But let's not forget that 50% of Down syndrome babies have normal ultrasounds. So that's another
right.
thing.
That's really hard.
Right. And it's not just for termination. There's so many reasons why someone would want to know. Preparation, etc. You may talk to different specialists before the baby's born just to really get ready. So, that's a whole different story. But
that's another whole nother Instagram live.
Right.
But yeah, I think the point we're trying to make here is if it's your choice to have antenatal screening. But we recommend it, and it's easier, especially if you're over age 37 to 40, especially over age 40, and we happen to see something minor on the ultrasound or a minor marker, and we need to do further counseling. It's so much easier to counsel you and determine what your risk really is if we have that antenatal screening and it's negative. So I think we've stressed that enough.
Yes.
Okay. So actually, I'm going to take a pause, and I'm going to go through and answer. Oh, my goodness gracious. A lot of questions. Okay, hold on. Hang in there. Can you see these questions, Dr. Alrahmani?
I can't see that. Are you getting a question box or just...
No? You must not be seeing because they're scrolling up on mine. Okay, so I may not get to all your questions. If I don't, I apologize. Let me start. Okay, here. I am 35 plus years old. This is another woman. Fetal death due to induced labor at 20 weeks. Does that make me high risk and an immediate IVF candidate? That's not enough information. I'm not sure why you would be induced at 20 weeks, what the reason was for that. And as far as I know, having a baby at 20 weeks would not be an indication to be an IVF candidate. I think it depends. In general, the rule of thumb is if you're over 35, 6 months of trying naturally to conceive and you're having normal periods and you're unable to conceive, then consult a fertility specialist. Over age 40, it goes down to 3 months. But that's if you're having normal menstrual cycles. Okay, if you're having problems with your menstrual cycles and you're older, then you might want to see someone sooner. Agree?
Agree.
Yeah. So and we're not fertility specialists at all, but we do. I went through a lot of IVF, so I know some about it. But one thing a lot of women ask me about when to see a fertility specialist over age 35 and 40. Yes, it's 6 months and then 3 months, but that's if you're having normal periods.
Right.
And that means normal length of cycle, normal, and they're not all over the place or short and then long. That's not a normal menstrual cycle. So if you're having problems with your menstrual cycles and you're over age 35 or 40, then I would see someone sooner than later.
Yep.
Okay. Let's go on down. The Wig Diaries, I know you. Thanks so much for this information. You all are so kind to share your time to help inform us. Well, we appreciate that. Okay. We're going to go to Miss Valentino. I am 41, having a baby in 3 weeks, and had preeclampsia with my son. So I've been seeing a high-risk doc through my whole pregnancy. And that's perfectly fine. Sometimes it depends on the center. Some centers It's more of if someone is over age 35 or 40 and they've had this history or they have something in their current pregnancy, the docs, it's just the way the system's set up, the docs sends them to the MFM. But it also has to do with the comfort level of the OBGYN as well. Right. So, and that's perfectly normal. Okay, oops, let me go down. Okay. If someone is taking vitamin D, iron, and folic acid pills before getting pregnant, would you still recommend they get the actual prenatal pills, or are those 3 enough? You want to take this one?
Yes. Take the prenatal.
So what I would say to this, the prenatal pill comes with what you should have. When you start piecing them out, you're still leaving out a lot, and you don't want to do all those 3. First of all, it's going to make you really constipated, okay, if you get pregnant. So you don't want to take all those pills. My advice, start out with a good prenatal pill with 1 milligram of folic acid in it. Okay, I think most prenatals have 1 milligram now. It used to be 400 micrograms. Now it's
I think most, the ones that I've taken had 800, which is
800. Okay, so 800.
Good, so
what we're talking about, the general recommendation before is most prenatal pills had 400 micrograms. Well, now it's increasing to where they're 800 micrograms or 1 milligram. Right. So I recommend at least 800 micrograms each prenatal vitamin. And then if you're doing that, then you shouldn't have to take everything else unless you're anemic. Once you're pregnant, you will get your blood count drawn. If you're anemic and your doctor feels like you should, or obstetrical care provider, should take additional iron, then they will advise that. But you don't have to take all of that, all those pills together. Just get a good prenatal vitamin.
Yeah, don't forget gummies don't have iron.
Okay, I was going to ask you. You're reading my mind. Talk about gummy vitamins.
Okay, I took gummy vitamins because I couldn't keep much down. Let's say that I could barely keep the gummies down. They're smaller. They are, I think, not as regulated as the regular vitamins. I just tell patients that they're pretty equivalent, honestly.
So what I do with gummy vitamins, they have to have a good reason not to take the ones that I prescribe.
Right.
And it's generally the ones who can't swallow pills or have bad morning sickness, okay? Those are really the only 2 exceptions where I'll say gummy vitamins are okay. And if they're taking gummy vitamins, I tell them to take 2 instead of 1. But as Dr. Alrahmani just said, they don't contain iron, okay? No. And a lot of these prenatal vitamins do contain iron, okay?
Yes.
So if you're taking the gummies, you need to let your doctor know because they may want to prescribe you extra iron, okay, if you need it, if you're anemic. Yeah. So just make sure you understand that. Okay. So how accurate do you think PGS embryo screening is to predict Down syndrome? So I had all of my embryos tested. The testing is not 100%, okay, because and we're not going to get into fertility much on this combo, but I'll say this real quick. You know, there is some concern that maybe there is a mosaic embryo there, but we won't good. But you have to rely on the PGS. If you're getting PGS testing, you have to rely on it. Yeah. Because the doc, if they did the testing and you paid for it and you transfer an embryo that's abnormal, I mean, I don't think any of the RRs are going to do that. So it's pretty good, reliable testing, but I'm sure it's not 100%, but it is what it is. If you have a reason to get the PGS, then you're kind of going to have to rely on it. Would you agree with that?
Agree.
Yeah. I had 5 cycles of IVF, 16 embryos that made it to the testing stage, and only 1 was genetically normal. But I was age 40 to 42 when that was going on. So, I think most fertility centers definitely recommend PGS screening on anyone over at 40, and some of them even go down to 38. Is generally what I've heard. Yeah. So if someone is on the borderline of overweight and obese based on BMI and they get pregnant, what can they do to have a healthy pregnancy? Dr. Alrahmani?
They get pregnant. What can they do? Okay. So I always do advise that they see a dietitian early in the pregnancy. I mean, there is recommendations for how much weight you should gain. Mm-hmm. It's really hard, sticking to these guidelines, but just to kind of have a healthy lifestyle. ACOG also recommends getting moderate exercise most days of the week, at least 30 minutes a day, just healthy habits, and also talk to your doctor. So advanced maternal age, so age over 35, plus any other minor factor would maybe qualify you for taking baby aspirin, for example, to lower your risk for preeclampsia. The patients with higher BMIs do have higher adverse outcomes in general.
Yeah, so what low-dose aspirin or baby aspirin has actually been one of the, I think it's a great thing that we now have guidelines for who are candidates for taking a baby aspirin in pregnancy. A BMI, I think it starts over 35 is an indication to take one. But there's a whole bunch of them, okay?
Right.
So women, it's relatively new. So whenever I recommend it or say, hey, this is why I want you to take this baby aspirin, a lot of them will get scared. I've even had pharmacies decline it because they're not exactly on board. So, but I want everyone to know, if your doctor recommends that you take a low-dose aspirin, you can ask why. What is the reason? But there are very clear guidelines on who is a candidate for taking baby aspirin. The most common reason women will get it, over BMI over 30 for multiple gestations. A history of preeclampsia is the most important one. Or chronic hypertension. What are some other ones? Can you think that? There's diabetes. So those are some reasons why. What was the last thing you said?
Lupus.
So those are some of the reasons why your doctor might recommend you start taking a low-dose aspirin throughout your pregnancy. So that's normal.
Yeah.
Okay. So we're going to talk a little bit here. Another one of the points that I wanted to talk about is that a woman pregnant over age 35 is considered high risk based on age alone, because of having the risk of having a baby with chromosomal abnormalities like Down syndrome. So we had already talked about that a little bit earlier on. Why that was basically because at one point in time, 35 having a baby with Down syndrome at age 35 was roughly equal to having a complication from an amniocentesis. And just real quick, the amniocentesis, which is where the needle goes into the belly and we take off some fluid from around the baby and send that for testing, is the only way to know in pregnancy 100% for sure. It's diagnostic. If the to tell whether or not the chromosomes are normal. There's no other way to do it unless you did something. Even CBS, is CBS considered diagnostic now? I mean, we don't hardly do it anymore.
We actually do a bunch.
You do?
Yeah, not as frequent as amnios, of course.
Right.
The problem is if it's positive, if the CVS is positive, it doesn't necessarily say that the amnio is positive, because you can have the mosaic in the placenta. So.
Right. So, and I think you're right. So, again, a lot of centers, there's not a whole lot of centers that I've never even seen a CVS in my career, but I haven't, but I've done a gazillion amnios. So, the amniocentesis, which is the earliest it's usually done, is 15 weeks, ideally 16 weeks and above, is the only way to know. So we already talked about doing the antenatal screening and how we both feel that it's important to have that on board, especially if you're over age 40. And one other point I wanted to make is that the whole thing about having an increased risk of having a baby with a chromosomal defect like Down syndrome, the reason why that occurs is because as we age, our eggs are aging, and it doesn't matter how healthy we are, our eggs are still aging. So a lot of women think that, well, I'm healthy, I exercise, I work out, I eat healthy, I'm a vegetarian, I don't drink alcohol, my eggs are fine. Your eggs are still 40, your eggs are still 39. So unfortunately, your health, how healthy you are, doesn't have an impact on whether or not your eggs are going to have genetic issues. So myself, I was 40 and I was perfectly healthy. I did spin classes. I was in top shape. I didn't have any genetically normal eggs. Yeah. And, and it is what it is. So I hear a lot of things about, if you take this, you can improve your egg, and it's called egg quality is what it's called. You can improve your egg quality. If you take this over the counter, talk to your fertility specialist first before you start doing all that, because there is no data showing that anything we take or do improves egg quality.
Right.
Okay. So I want to make sure women understand that. Do you have anything to add to that?
I agree completely.
Yeah. So the other thing that we would talk about is that a woman over age 35, and especially over age 40, does have an increased risk of pregnancy loss. And that's mainly due to the odds of having a miscarriage, which is basically losing a pregnancy before 20 weeks. And that starts to rise over age 35. It's like a steady rise and then kind of a much more steep rise after age 40. So there is an increased risk of pregnancy loss, and that's namely due to the genetic part. So a lot of first trimester losses in these women, because the eggs are older and they don't result in a genetically normal embryo. You may end up with what's called a chemical pregnancy, a miscarriage. You may end up with a later loss of 14, 15, 16 weeks. So it does happen. How do you counsel your patients when they ask you about what their risk of having pregnancy loss is?
So we just talked about that the risk is higher after 35. Unfortunately, the risk of having stillbirth also after 20 is higher with age. Again, nothing magical happens, but do you guys do anything differently for these women to monitor them throughout the pregnancy?
Even if they had normal antenatal screening, they had normal ultrasound, we don't do NSTs just based on age alone.
Yeah.
We don't do BPH.
And ACOG doesn't recommend that.
No. So what we're talking about is, if you're otherwise healthy and you're over age 35, 37, 40, you don't have any medical conditions like high blood pressure, diabetes, anything like that, should you be getting an ultrasound every 4 weeks? Should you be getting NSTs? Should you be getting BPPs? The answer is no. We don't do any increased surveillance unless there's other factors on top of the age. Yeah. And I think that's what you guys do as well, right?
I do offer it because we do it here.
Okay.
Which I also haven't, the studies are very conflicting anyway, but I offer it to some patients, take it, some patients don't. I don't necessarily recommend it like I do for a diabetic mom or a mom who has preeclampsia, hypertension, but I'm very conflicted still on it. So
yeah. Now I think as a rule we haven't, and again ACOG hasn't said that they based on age alone either. So but there probably are some centers across the nation that do, and that's fine. So you just talk to your doctor. The other thing I wanted to touch upon is a lot of women who are over age 35 and 40 and are healthy. It doesn't matter how healthy you are, you're still at increased risk for certain things based on your age alone. We already talked about the pregnancy loss. We talked about the potential for Down syndrome and other chromosomal abnormalities, but we also need to talk about having an increased risk for diabetes, high blood pressure, preterm birth, cesarean section, placenta previa, preeclampsia, which goes along with the high blood pressure. And then there's also certain complications after delivery in the postpartum period. So what I tell women, I don't necessarily think it's a bad thing that we pay more attention to you after age 35. Yes, we monitor all women for these things, but when we have a woman over age 35 and 40, we kind of make sure we are very, vigilant for them because they are at increased risk for these things more so than a woman who's 25. Right. So, and you also should be informed as well as someone who's older and having a pregnancy that these are certain things that we need to be on the lookout for. Mm-hmm. Yeah. So, I know women don't like to hear that, and I get it, but and more women are having babies after age 35 and 40, and it's perfectly fine, but we have to be realistic, we have to be informed, and we have to accept that there are some things that could go wrong, and hopefully that your obstetrical care provider is talking to you about those things.
I agree.
Okay, here's a question. Let me go back down. Is someone do they get pregnant? I am 38, trying to conceive for a second kid over a year. My daughter is 4. Lamontarock, I think is the name. So if you're over 38 and you've been trying to conceive for over a year and you're having normal menstrual periods like we said before, and you're having intercourse and you're ovulating, because I'm sure people are doing ovulation kits and everything, then it might be time to see somebody. Seeing a fertility specialist does not mean they're going to stamp IVF on your forehead right away. There are other things that people can do or recommend, the docs can recommend that you do beforehand. So it might be times, if it's been that long, to see somebody. Would you agree, Dr.
Absolutely. Yeah. I mean, it's just a consultation. It doesn't hurt to get more information. I mean, knowledge is power. So I think that it is very important if you've been trying to to get pregnant, regardless of your age. If you feel like it's been too long, a year is usually a good time to say, okay, then let's see what other information I can get. But it does not need to be IVF.
Right, and and there's another thing too. Women are seeing, and there's some fertility or treatments that general OBGYNs can do, right, but it is kind of limited with what they can do. So if it's been over a year and you might want to get a second opinion, again, it's like Dr. Alrahmani said, it's just a consult. It doesn't mean they're going to sign you up for a treatment right away. It might be better to just go ahead and talk to them just to get a second opinion. And I want every woman to know it's always okay to ask questions. It's always okay to get a second opinion. That is your right to do for anything in your pregnancy, if you're concerned about something.
Exactly.
Mm-hmm. Let's see. Oops. Okay. You guys always sneak in these fertility questions.
I know.
Okay, hold on.
Oh, wow. Okay.
So, what are your thoughts on CoQ10 supplement for both men and women while tried to conceive? I have no idea about it for men.
No idea.
I took it before I started IVF. I was over 40. I don't know if it helped. Oh, obviously it didn't help. I ended up doing IVF. So honestly, I don't know a whole lot about it. Again, I think it's not going to hurt, but as long as you let your doctor know you're taking it and that someone knows and is regulating it. I mean, it is over the counter, I get, but they still need to know what you're taking. Okay. This is from Tiffany Britt Desens. Can you test the quality of your eggs before getting pregnant? No. Unfortunately, what we can do is what docs can do is test the your ovarian reserve, which is an AMH. They can test to see, but that can only tell like how many eggs you might have or you're being able to ovulate. But they can't. There's no test to say whether or not the eggs that you have are genetically normal. Unfortunately, so the answer to that is no. Okay. Yeah, we're sneaking in all these. Okay, I'm doing embryo adoption of PGS tested eggs where the genetic mother was 37 at retrieval. Okay, well, I'll hopefully be 31. Should I see a high risk dog due to the age of the genetic mother? So basically, I did embryo, got pregnant by egg donor. The mother of my that donated the eggs was 25. So the age of the mom who provided the eggs, the age of the woman who provided the eggs is what the factor is. Okay, so if she was 37 and it was PGS tested, that's great, but they're probably still going to do antenatal screening on you and the detailed ultrasound and everything. So the PGS is only giving an indicator of which embryos to transfer, but you still need to follow through with their pregnancy as if the person is 37. Did I say that right?
Yes.
Okay. All right. Okay. So we're a little bit over another important topic. How do you counsel women with pre-existing medical conditions one thing that I find, but I also have a patient population that don't have access to medical care routinely until they get pregnant. So we have a lot of women who have complicated health histories and pre-existing medical conditions, and then they come into their pregnancy and we're kind of playing catch up, and which can be very difficult. Pregnancy is not the best time to play catch up with your blood pressure and your diabetes or your lupus or your heart disease or anything like that. So tell me what your thoughts are, but I always recommend any woman, if they can, and they're planning a pregnancy, to get any medical condition they have optimally controlled before they get pregnant.
Absolutely. Preferably tell people that you want to be pregnant, so the medications that you're on would be compatible with pregnancy. We don't have to change them right away, especially with high blood pressure. Had a patient recently on these medications that I haven't heard of since medical school, I guess, and I was like, okay, well, we'll just keep going. But, I had to look up the medications because I don't know how to deal with the doses and things like that. But I actually have, my patients are, I guess, very different from yours because we do a lot of preconception consults.
Yeah.
A lot.
Yeah. So I'm in two different eds because I don't ever get them. Most of my patients are indigent. About 85% are indigent. Oh, actually, 99% are indigent. Less than 1% have private insurance. So we unfortunately we play catch up a lot, which is difficult to do. So, So, and just along the same, tell people what a preconceptional counseling visit is.
So so basically they would see an OBGYN or their family doctor or myself prior to getting pregnant if you would have any other medical issues. So that does include advanced maternal age. If that's the only thing you have, then fine. If you have high blood pressure, diabetes, lupus, we talked about that, anything that you can think of, a previous history of a preterm baby, things like that. We just basically talk about your risk for the pregnancy, if you'd be a candidate for a vaginal delivery or not, what gestational age would I hope to deliver you if things stay this way. We'd go through some scenarios as well, and really optimize your health. And for certain things like seizure disorder, for example, I always recommend let's try to get you down to one medication if possible, rather than the 3 that you're on. Just things like that your maybe neurologist didn't necessarily think about before pregnancy if you've been so stable, just things like that. So it's a long consult because we do go through a lot of scenarios, but I think it's very helpful for people, and especially when a mom when she gets pregnant, comes back to me, then it makes the consult very easy.
I think preconceptional counseling is highly underutilized. I think a planned pregnancy, especially in someone who has any kind of medical condition or is on medications on a daily basis, is so important because we can get things as optimal as possible so that you can get pregnant. There are two, and you can agree or add something else to this, but there are two situations where I see all the time. They're on medications for seizures or mental health disorders.
Yes.
Whoever they see says, stop taking everything.
Oh, yes.
And by the time they get to me, they've already started having seizures again. They're already depressed and having anxiety or having, manic episodes. And I can't stress enough that those are probably the two most complicated ones that are very hard. If you stop all medications, their family practice doc might say, you got to stop everything until, I've even had emergency medicine doctors tell them, stop everything until you see your OBGYN. It might be a month. And women who have seizure disorders, they can't wait a month. Or if they have bad depression or anxiety. So a knee-jerk reaction is not to stop all your meds. If you're on medications and you've been controlled for anything and you find out you're pregnant, you call wherever you're planning on getting your prenatal care and say, listen, don't just say I need a new OB appointment. You say, I'm on these medications. So that we can, if we can't get you in right away, we can at least do a phone call visit with you and give you some guidance on if those medications are okay to stay on until you see me. But don't just stop everything, okay? Because that can cause more problems than it's worth. What is your experience? Do you see much of that?
Yes, I do. Luckily, our patients do communicate with us, but then I would get yes, the ED doctor told me not to take this medication. It's something as simple as an anticoagulant that is not warfarin, right? It's not a category X. Stop everything until you get your appointment, which is in 4 weeks. And I'm no, we can do this. Just keep doing it in the meantime. Or, it's very easy. But yes, uncontrolled disease has a lot worse outcomes than
taking the medication.
Most medications.
Well, the easiest way we could say it is a healthy mom is a healthy baby, and a mom who's having seizures, or a mom who's severely depressed, or a mom who, that's not healthy for a pregnancy either. So, again, if you can at all have time, and I know surprise pregnancies happen all the time, but if you are trying to conceive and you have any pre-existing medical conditions and you're over age 35 and 40, do that preconceptional counseling visit. It is paid for by definitely by private insurances, and I think by most Medicaids, so that we can get you controlled before you get pregnant. That would be very ideal.
Yes.
Okay, so let me just see. We'll do a few more minutes, and let's see. If everything was okay. Thank you. See, I'm 38, and my first child is 8 weeks old. How soon can we start trying for baby number 2? That depends on you. I mean, I'd like to, my mom had my sister and I, we are almost exactly a year apart. You have to decide what you are comfortable with, having a toddler and a newborn, which is essentially what would be happen. But, there's no magic number. I can't say you need to wait 6 months. You need to wait 3 weeks. I think it's on the comfort level of you. And if you're breastfeeding and you're not having periods, well, then it's going to take longer for you to get pregnant. Doesn't mean you can't get pregnant, but it might take longer. So it all depends on your situation. This is for on QFit. Do you have anything to add to that? What do you tell patients to wait a certain amount of time?
We used to say, you would need to wait 2 years between pregnancies. That became 18 months. I mean, there might be increased risk for, certain things if you have babies less than a year apart, especially if you've had a previous C-section, but
that's the key. So if you've had a previous C-section, it's not ideal to get pregnant right away because you want that uterus to have time to heal. But I think every doctor is a little bit different on what their comfort level is. I would rather a patient, no matter the age, if she's had a C-section, wait at least 18 months to get pregnant. Mm-hmm. I know that doesn't always happen, but if I had my way, that's what I would say. So do you kind of generally tell them that? I think
I usually say 18 months between deliveries.
Yeah, right.
But which is like a year, basically.
Oh, yeah, okay. So 18 months between deliveries, yeah.
Yeah, but it's there's a few things that would increase shortens her pregnancy interval, but no, you're 38 and you would just want to get this out of the way or something. Your risks for other things also go up if you wait too long.
Okay, this is from Lasavis. I'm 34. Should I skip IUI and go straight to IVF? I don't know your situation. IVF is not the cure-all, okay? You're still actually, 34 is not too old, okay? So if you're having normal periods and regular periods, and IUI is indicated, again, I don't know your total situation, but if your provider is recommending IUI, try IUI. I don't see why not. But again, I don't know enough to actually tell you whether or not you should go straight to IVF. But just because you're 34 shouldn't be a reason to go straight to IVF. Yeah. Okay. Let's see. Okay, so that's the end of the questions. We're going to wrap this up. If you have any other questions, you can private message myself or Dr. Alrahmani. She's on my Instagram stories and on the feed. You can get her Instagram there. One thing I wanted to close off with is that if there's so many things that can make you scared, and it's not sometimes the doctors make you scared of being pregnant over 35 and 40. There are some doctors who do make you scared. I understand that. Yeah. Your family members, your social media group, the internet. You could read so much about all the terrible things that can happen. The reality of the situation is more and more women are delaying childbearing because they want to have careers and do other things before they had children, which is perfectly fine. I did that and I advocate for it. But we have to be mindful that the longer we wait, there might be more issues. But that also doesn't mean that you can't have a normal, healthy pregnancy. There are plenty of women who have normal, healthy pregnancies, especially those who are ready and are motivated to have a healthy pregnancy and are willing to do what the doctors recommend and take care of themselves and all of that. And, I see plenty of successful women having pregnancies, healthy babies after 35 and 40. So I don't want it to be like it's going to be a terrible experience. It's not for everybody. So hopefully that you guys don't take that away, that we're trying to scare you.
Absolutely.
Yeah.
Thank you so much for having me, and thank you for everything that you've been doing. I've been following you forever. I'm a huge fan.
I've been following you too. I know. So we'll have to do this again. I'm sure there's going to be more questions, and I appreciate you taking your time. I know. What time is it 7:14 where you're at, or 8:14?
It's 8:14, yeah.
Yeah, so we're on the same time.
Yeah.
So I appreciate everybody that joined in. This will be on my Instagram Live feed. It'll be there permanently on Instagram Live. So you guys can go back and if you have any other questions, you can contact either one of us.
Perfect.
Thanks, guys.
Thank you.
Bye-bye.
Bye.